of AAHC. Next slide, please. So briefly, each year AAHC forms a President's Council and focuses on a topic over the course of the year. A year ago, the President's Council focused on cybersecurity and the ways that when our IT systems can be disrupted or hijacked or ransomware, strategies and ideas to prepare and plan for that. This year, the President's Council examined health insurance plans at academic health centers and innovative practices in population health. Our goals over the past year were to create an inventory of health plan models at academic health center AAHC member institutions, to create a set of descriptors of innovative practices in population health, to identify and annotate relative readings, and produce other materials deemed important by the Council. Tonight, we focus on Goal 2, creating a set of descriptors and describing innovative practices in population health at academic health centers in our member institutions. Next slide. These are the members of the President's Council for the past year. And I highlight Dr. Mir from the Leeds Academic Health Partnership, and also Dr. Carmen Padilla from the University of the Philippines, who were members of our President Council from AAHCI, our international component of our organization. Next slide. And so what we have found to be a really exciting and worthwhile format to learn a lot about a complicated subject in a very short amount of time are what are so-called Ignite-style talks. Today, we're going to hear from a number of colleagues about practices in population health at their academic health center. Their talks will be fast-paced, information-loaded. We ask each speaker to speak for 5 minutes. We've asked them to convey their material in 5 slides, and we'll then have each presenter present for 5 minutes, and then we'll have about 2 or 3 minutes to ask your questions on that particular talk. And then after we complete the series of talks, we'll have a few minutes for general discussion as well. Please, if you will, enter your questions into the chat box, and then we'll have them teed up and ready to go at the end of each presentation. So without further ado, we'll begin our presentations. Next slide. And our first presenter will be Dr. Low from Singapore Health Services. Dr. Low?
Yeah, thanks very much, Dr. Good, and a very good day to all our participants for today's Southeast Asia regional meeting. My name is Lian Ling. I direct the Population Health Office at the Singapore General Hospital. I'm also a clinical associate professor with the Duke NUS Medical School here in Singapore. So really thankful for the opportunity to present our work on improving digital access and literacy for socially isolated seniors in Singapore during this very bad COVID-19 pandemic situation in Singapore. The next slide, please. So the COVID-19 pandemic has really exacerbated the existing digital gap with older adults really being left far behind in the society. So many of them are actually displaced in this offline world. They find themselves isolated in their homes, losing contact with social support, limited access to information, and limited entertainment options. So they find this inability to exploit the online world with physical limitations caused by a lack of smartphones or internet that many of us take for granted, and limited access due to lower reading ability compared to the younger generations. So they are very much adversely impacted by these restrictions, many of them suffering from depression or anxiety due to increasing isolation and a lack of avenue to seek help. And all of us know that loneliness is associated with increased risk of morbidity, functional decline, and all-cause mortality. So during the COVID-19 pandemic, very strict social distancing measures in Singapore has exacerbated these feelings of social isolation, loneliness among our older adults. So in fact, during this period, the school conducted a Singapore Life Panel survey of senior citizens aged 55 to 75, and they found that this has resulted in much lower social satisfaction among our older adults. And contrary, seniors who reported using communication technologies like smartphones to make phone calls, to video call others on social media, actually reported higher levels of satisfaction and well-being. Therefore, we believe that if we can equip the elderly at risk with basic tools like mobile phones and Wi-Fi, we can help them to stay socially connected and lead a more independent and empowered life, which is immensely critical during periods of lockdown in COVID-19. The next slide, please. So the community wire up program that we have at Singapore General Hospital really takes a whole of community approach, where we work with various government agencies like our Ministry of Communications, the Information Authority, as well as industries like our telcos, telecommunication companies. Next. So the target population that we have for our Community Wire Up initiative are seniors aged 55 and above. And these are through referrals from our hospital programs, as well as our senior activity centers in the community. Next. So these seniors are then equipped with government subsidized or donated smartphones and mobile data plans. Next. For the next 3 months, our volunteers will engage with these seniors in over an average of 6 coaching sessions conducted either face-to-face or via a virtual platform over a period of 3 months. Next. And using a tiered curriculum, the seniors will be started off with basic smartphone features like how to turn on the phone, how to make phone calls, and then subsequently we teach them to master basic communication tools like email, WhatsApp, and also Zoom video calls. Subsequently, we'll progress them on to more complicated features like our digital government apps, like SingPass, Trace Together, which is important for contact tracing and social distancing, and then also various online banking apps. So at the end of the program, we then connect these seniors to the hospital's telehealth programs and also a national befriending initiative, allowing them to access various social and health services and widening their social network. Next, please. So our program evaluation is based on the mixed methods, quasi-experimental pre-post study design. So in the step wedge study design, we will assign 200 participants to the intervention group, whereas another 200 participants will be initially in the control group, but subsequently receive the intervention. Our primary outcome measures listed here, so very briefly, is on social isolation and loneliness, as measured by the Lubin and the UCLA loneliness scale, as well as improve personal well-being and quality of life. The difference between the two groups will help us to determine how effective this program is. And in addition, we will conduct qualitative interviews with the participants and the stakeholders to evaluate the feasibility and scalability of the program. Next, please. So from 1st July to 28th August, at the point of submission for this meeting, we have actually enrolled 282 older adults into the program, and currently 53 of them are still in the program in the midst of completion. The majority are elderly and with lower levels of education and really belonging to low-income communities. So only a slight majority of them own a smartphone prior to the program, and less than 1/3 had access to the internet or mobile data, and less than a quarter were able to use at least 2 smartphone options. So we found that 62% of them experience social isolation, and more than half were experiencing loneliness. And the preliminary results of our program suggest that we were able to reach out to seniors who are low in digital literacy and high in social isolation and loneliness. We have some preliminary results from some of the older adults who have completed the program, and we found that we were able to improve their social isolation, although there was only a marginal improvement in their well-being, presumably because many of the social distancing measures were still in place because of the pandemic. The next slide, please. So once these older adults have been wired up in our community initiative, we feel that they can then benefit from better social connectedness and health outcomes in our community. For example, you see here in some of our pictures that many of them are taking part in video consultations and telehealth, which are really important modes of providing medical care during this period or during periods of lockdown. They were able to attend virtual health talks in smaller groups, socially distanced apart, or even in the privacy and the convenience of their own homes. And finally, in the last picture on the bottom right, some of them were even able to connect with their physiotherapists and take part in tele-rehab programs. So I should mention that these are just some of many health and social benefits for the seniors in this program, and we look forward to more social connectedness and improvements as we wire up more parts of our community and expose the remaining seniors to the benefits of telehealth and tele-social care. So with this, I thank you for your attention for my short presentation, and I look forward to your questions and comments. Thank you.
Thank you for that presentation. We have time for 1 or 2 questions if you'd like to enter in the chat box. You covered it, maybe you covered it and I just missed it, but are you measuring any health outcomes? I noticed in your picture, one of the participants has a blood pressure cuff on. So measures such as blood pressure control or perhaps mental health screening for depression. Are there any outcomes related to mental or physical health?
Thank you, Dr. Good, for it's an excellent question. So what we are doing is that we're actually pairing up these telehealth video consultation services with what our existing community nurses are doing for population health. So now with these additional modalities to monitor the patients, they're better able to monitor and reach out to their patients and stay connected to them. So they're being measured as part of a broader chronic disease management program. Although the Wire Up initiative is more focused on improving social connectedness, personal well-being, as well as loneliness. Thank you so much for the question.
Great. Thank you. And thank you for that presentation. At this point, we'll move forward to our second presenter, Dean Siam, from who's Dean of the Faculty of Medicine at the University of Indonesia. Dean Siam.
Okay. Thank you, Dr. Good. Okay, good morning. So today I will talk about the brief report about our academic health system in Indonesia, role in combating COVID-19. I just want to give you information, the last information about the demography of COVID-19 patients in Indonesia. So on 16 November 2020, we have 470,648 confirmed cases. And actually we have a total case recover around 84%. And until now, we have what we call that the case fatality rate of our case is 0.2%. Actually, it is better than before, because on April we have around about 10% of case fatality rate at the time. So yeah, actually we have that we have a multi-center research study in our university. First, we have what we call that to study about the convalescent plasma therapy. So this is published in the clinical trial. We submit our research in the clinicaltrial.gov about the effectiveness and safety convalescent plasma therapy on COVID-19 patients with acute respiratory distress syndrome in the referral hospital in Indonesia. Because we make not only in our hospital, Cipto Mangunkusumo Hospital, but we have some hospitals as well to cover with this research. And also we have joined the WHO solidarity trial as well for treatment COVID-19 patients. And for the national WHO solidarity trial, one of our staff to be PI of this research, Professor Menaldi. And also we have some multi-center research study. First, stem cell research study. So also from this study, we work together with some hospital, not only our main hospital, Cipto Mangunkusumo, but also our university hospital and some hospital in Jakarta. Actually, we have what we call that to know that the role of herbals like guava extract. So from bioinformatics, guava extract is good for prevention. So now we have clinical trial to use this extract for supplementations patients with the COVID-19 in some hospital, also part of academic health system in Indonesia. And we developed artificial intelligence for COVID-19 detection as well. So we work together with Delft Imaging System. And for this equipment, what we call that the code CAT for COVID will generate a score between 0 and 100, indicating the extent of COVID-19 related abnormalities, such as the lung abnormalities, head map, and then quantity of the percentage of lung that is affected. So until now, we are still going on, the study is still going on. So we are waiting the result of our artificial intelligence for COVID-19 detection. I think this will benefit, that the Indonesia consists of more than thousands islands. So it is easy to our clinicians in the rural area to detect COVID-19 diagnosis. And also we develop some innovation things like what we call that the pneumatic system-based local transfer ventilator. So this is a multidisciplinary research from Faculty of Engineering and also Faculty of Medicine, and then UI Hospital and Health Polytechnic, and also from Minister of Health Hospital, like our main hospital, Cipto Mangunkusumo, and also Persahabatan Hospital. So now we have shared our ventilator to some hospital, not only in Jakarta, but in some place in Indonesia. We developed what we call that the flock swab. Before, we must import this equipment. So what we call that the hope and solution for COVID-19, HS19 flock swab now being produced. Yes, because this is produced from university. So after facing research and testing conducted by researcher from UI, especially from Faculty of Engineering and also Faculty of Medicine. So we work together with industry to produce this flock swab. And now we share our flock swab not only in Jakarta, but also in some hospital in Indonesia as well. And our student to develop what we call that in Corona. So this is one of educational platform and COVID COVID-19 risk detections designed by our Faculty of Medicine student and also joined with the Faculty of Computer Science student. And for educations, we develop what we call that online module implementations during pandemic, and not only using from our student, but also share to some Faculty of Medicine in Indonesia as well. And you know that this module also used from intensive doctor who sent to some places in Indonesia. Okay, and then yes, the conclusions of my talk, I think the COVID-19, we are agreed that the COVID-19 pandemic has forcefully disrupted every sector, including education and also healthcare. And then the spreading of COVID-19 across the globe has necessary innovation for every aspect, and the academic community is forced to make the breakthrough innovation, and our struggle to fight and COVID-19 pandemic will change our lives forever. Thank you for your attention.
Thank you for that very thorough review and presentation. Are there any questions from members for Dean Siam? I have one. I was very intrigued by the artificial intelligence mapping of the lungs. And if I read that correctly, it actually generates a score. Is that still just in a research mode, or are you using that AI score to perhaps guide therapy?
Yes, actually, this is still going on research. So we hope that we can produce the programs how to use this for, to help our clinicians in the rural area. So this is still going. Yes.
In the rural area, help them, for example, determine therapies and then whether to transfer or not, things like that.
Yeah, and also to make a precise of diagnosis of COVID-19.
Ah, I see. Very good. Well, thank you again for that excellent presentation. Our next presenter is Dr. Akun from the Duke NUS Academic Medical Center in Singapore. Dr. Kung.
Thank you, Dr. Good, and a very good morning to everyone here. And this morning, I'll be sharing with you on the PACIT care model, which stands for the Primary Care-Based Integrated Community Care Team, who's enabled by technology to deliver person-centered care to patients living with diabetes and have complex needs in the community. I'm a family physician and I work in SingHealth Polyclinics. Next slide, please. And we are part of the SingHealth regional system. So SingHealth Polyclinics is a network of 8 medium to large size clinics providing public primary health care in the eastern part of Singapore. So through this initiative, we will showcase how the primary care team partners with the community care team to deliver care to this particular segment of patients with complex needs. So in the photo down below on the left, you would see a typical, this is the clinic where I practice in, and the one on the right, you would see the blocks of flats. Actually, these flats goes much higher, like 20 to 30 floors. And you would see that in the space on the ground floor, these are spaces sometimes from which our social service agencies, as well as our community nurses work out from in close proximity to the patients and where they live. Right, so the next slide, please. Right, so complexity in this segment of patients that we manage, they arise from interacting or co-present or sequential disease, as well as psychosocial and environmental factors that impact the delivery of usual care. So can I have you help me to animate? So some of the profiles, can you just press the enter button, please? The profiles, yes, for the complex needs typically would involve a patient with multi-morbidity, like in this patient. There are also red flags with high healthcare utilization. Other red flags would include low activation, the difficulty in the healthcare team in engaging the particular patients. The enter button, please. Right, and enter button again, as well as a host of social factors that are barriers to actually care being effectively delivered. In this case, financial issues and poor family support. Right, so the enter button again, please. So the gaps today that we face are plenty. So just to name a few, care often falls apart for these patients when they go out from our clinics because of the lack of communication between providers, as well as the lack of time to actually understand the whole context of the patient. The next slide, please. Right, so this was a collaborative effort from the start. And so what we did was to gather the providers that frequently are in the care for these patients. So healthcare providers in the primary sector, in the community sector, as well as our social service partners and our funders. Next enter button. So we started by mapping the journey of the patient with each provider, and not surprisingly found several overlaps. So the overlaps are actually in the form of the type of care that we provided for the patient. The overlaps was also in the form of data that we collected. So amongst the providers, we collected about 530 fields in total, and the team crystallized the data fields to about 70. Which were crucial to the delivery of the care. And the 70 were obviously overlapping in several of the 530 fields as well. So we were then able to organize the data into a framework, which we later used to develop in the mobile application. So the next enter button, please. So what we did next was to visualize the ideal journey, right? So what if we collaborated and we worked together? What would the ideal journey look like? So through this exercise, we gained clarity of our roles. So we realized that we had a predominant role, and we also realized where we complemented each other in the community. So there were also processes, IT, and other elements required that we identified that would support this model of shared care. The enter button, please. And so finally, we came up, so this whole almost year-long exercise, because it included the development of the app, brought us to a common vision, really, to have different parties come together with the common objective to improve the care and to meet the care needs of our patients, to improve their care experience as well. We were also able to articulate the values of what we hope to deliver, what we meant by person-centered care delivery, and importantly, also the spirit of collaboration amongst partners who do not really belong to the same unit of organizations. So this was really from relationship building and respect. Right, so the next slide, please. Right, so in a nutshell, so what we're testing today is the PACEIT intervention, which largely made up of two components. One, which is the integrated multidisciplinary care team. And this is a care team which brings together the providers from the healthcare sector, the social care sector, and the care coordinator as well, who actually is the point of contact for the patient, who helps the patient understand the care plans, to be able to help the patient to navigate the care plans as well as the community nurses in close proximity within the residential area for midpoint reviews in between clinical visits. So these are predominantly our roles. We have shared processes. So for example, the onboarding processes. So there is little need for referrals because we have a semi-structured care path with major touch points that would allow home visits, visits to the community center nurse post, as well as clinic visits. And this team is connected through regular virtual meetings. Can I have the enter button, please? Right, as well as the next bit of the intervention, which is the mobile application that we developed. And this is the communication platform that allows information sharing amongst the 4 providers. So this is where we organize the information that we collect. We also have access to the care plan that we come together to deliberate and prioritize after we've collected the information. So this tool also allows the care providers to communicate using the chat function, as well as task schedule. And so it allows for coordination of care as well. So this model is being tested in an RCT, mixed method RCT, non-blinded study at this point in time. And we are testing the effectiveness and the feasibility of this care model with the primary outcome of improving glycemic control, secondary outcomes such as improving the quality of life, improving patient activation. And this piece of work was really a ground-up initiative, and we hope that we can pave the way for more health and social collaborations in the community. And I think what's important is that we also managed to show the way of how we could share data in a secure platform and in a meaningful way so as to better coordinate care. Thank you very much.
Thank you for that presentation and a nice review of your project and your work. Are there any questions from members of the audience for Dr. Kung? I have one as shown in here, you've assembled a really nice care team. Tell me a little bit when mental health challenges are encountered. Do you see mental health challenges in some of your patients, and then how are those handled by the care team?
Yes, so mental health would be quite a regular issue with this segment of patients. So I think the first step is really about assessment, right? So there is a structured assessment in the care path to ensure that our patients are assessed for issues like depression and anxiety. So the second bit of thing would be the primary care physician, and this care team who is very close to the patients providing the support. So this is the first layer of care. And failing which there are also community resources that we tap in. So there are other, so this little care team then branches out to other programs depending on the severity of the mental health issues that needs, for example, institution involvement. The social service agencies also will play an important part because of the activities that they have within the community. So if the mental health issues are really just quite mild and early, so this is where we can nip it in the bud, get them to participate in the activities and to improve the mental health earlier on. Yeah.
Great, thank you. Yeah, I suspect that social service agency team member is very helpful in that regard.
Yes.
So
that's right. Yeah. So they tend to provide the services, provide the context, and be able to tell us things about our patients. And they are like the advocates for our patients sometimes, because the medical team sometimes get overboard with prescription, with referrals, and I think the nuance that they introduce to the care team is a really important one. Yeah.
Great. Thank you so much for your presentation. We'll move on now to our next presentation from Dr. Belisario from the University of Philippines in Manila. Dr. Belisario, please.
Thank you, Dr. Good. Unfortunately, Dr. Belisario cannot make it today. So on behalf of Dr. Belisario and the NTD study group, I will be delivering our findings on the remaining pockets of SDH burden in indigenous peoples in the Philippines. Next slide, please. Neglected tropical diseases are communicable diseases that prevail in tropical and subtropical regions, where populations live in poverty without access to adequate sanitation. Soil-transmitted helminthiasis, or STH, is among the 20 NTDs targeted for global action. Globally, an estimated 1.5 billion people are infected with STH, with transmission occurring by ingestion of eggs or by skin penetration of hookworm larvae. Some of the morbidities caused by STH are abdominal pain, stunting, anemia, and poor school performance. Next slide, please. Global and national targets have been set for STH control. Among these are prevalence and intensity targets, as well as MDA and WASH coverage targets. The National STH Control Program in the Philippines has been implemented for almost 14 years with three main components: deworming, provision of WASH, and health promotion and education. For this presentation, a hotspot was defined as a location where prevalence and/or intensity does not show a reasonable decrease. In the Philippines, hotspots are unable to be detected by current national policy and program. If you would look at the rightmost column of the table, you will observe that there is currently a moderate prevalence and heavy intensity of STH in the Philippines, with 12 provinces still above 50% prevalence. There has also been a recent challenge in meeting MDA coverage targets for both preschool-age children and school-age children. It must be noted that although deworming by MDA is the main morbidity control strategy for STH, it is only one of 5 strategies for the control and elimination of NTDs, such as SDH. Low access to safely managed water and sanitation facilities has also been noted in the Philippines. Next slide, please. Yes. We have identified indigenous peoples as a remaining pocket of high endemicity. These groups commonly live in poverty and reside in hard-to-reach areas, limiting their access to quality health services and wash facilities. They are also not reached by health education initiatives, resulting in poor knowledge, attitudes, and practices. This makes the practice of open defecation very likely in these areas. Apart from these, there is also very limited data on their health status. From the table below, you can see the moderate to very high prevalence and intensities in these areas. Some of these values are well beyond the global and national targets for SDH control. Next slide, please. Our studies were able to identify points of action and the respective roles of various sectors. For research and the academe, focus must be given to identifying causes of remaining pockets of high endemicity, as well as development of models for enhancement of service delivery. Policymakers should include identification of hotspots in the national policy, as well as disaggregation of data to better understand equity in at-risk groups, to identify gaps in service delivery, who are left behind, and why they are left behind. Now, the main approach utilized and being proposed by our studies is the War on Worms, Nutrition, and WASH framework, or the WOW and WASH framework, integrating parasitologic, nutritional, and WASH assessments to generate data that provides evidence for enhancement of policy and improved service delivery. Through this approach, we were able to identify the need to address the coexistence of parasitism and poor nutrition in these groups, along with other factors contributing to high prevalence and intensities. Our studies were also able to provide models for the use of existing platforms for collaboration, such as the existing public-private partnerships in one area and the GIDA platform in another, to develop approaches aimed at improving intestinal helminthiasis control and achieving desired health outcomes in these marginalized groups. Engagement of organizations outside the government and the private sector must also be done for continued WASH investment and development. Lastly, intensive and culture-sensitive health promotion and education initiatives must be conducted to improve sanitation and hygiene practices, increase compliance to treatment, and promote participation in other SDH control activities. In sum, as usual modes and methods of service delivery do not work in these areas and populations, extraordinary efforts are needed to address remaining pockets of high endemicity in the Philippines. Thank you very much.
Thank you for that presentation and review on certainly a subject that was not familiar with, and clearly is a public health and requires a population health approach. So very fitting. Dr. Lumangaya, toward the end, was it the university and the health center that assessed this and brought the government in to help, or was it the government trying to do its work and brought the academic health center to assist the government? Kind of who led whom here?
Yes, actually, the academe, or Dr. Belisario, was one of the members that initiated the SDH control program in the Philippines. Our studies were the basis of the national SDH control program, and we have engaged the local government units as well as other regions so that we would expand the approach being used by the national policy for continued improvement.
Very good. That's really nice. As we go through these talks, we're seeing some of the components of population health. In this case, interactions with governmental agencies. In previous talks, the role of technology, and in one of other talks, that it's a healthcare team that actually comes together. So thank you. Any other questions for Dr. Lumangaya from the audience? Okay, again, thank you. And my apologies for getting the wrong presenter. Thank you for being here.
That's all right. No worries. Thank you.
Our next presentation is from Dr. Guo from the from Singapore Health Services in Singapore. I'm sorry, I'm getting my own notes mixed up again. From the Academic Medical Center in Singapore, Dr. Guo, please proceed.
Thank you, Dr. Cook. Good morning, everyone. It's an honor to be here today to share with you on our Integrated Maternal and Child Wellness Hub, a collaboration between KK Women's and Children's Hospital and SingHealth Polyclinics, funded by Temasek Foundation. My name is Xiaoshen, and I'm the Clinic Director at Punggol Polyclinic, the clinic that this program is being piloted at. Punggol Polyclinic is one of 8 clinics under SingHealth Polyclinics. We are a public primary care center serving the residents in the Punggol estate, which is in the northeast corner of Singapore. Punggol is a young estate with the highest number of children in Singapore under the age of 4. Next slide. The Integrated Maternal and Child Wellness Hub, or IMCWH for short, is a 2-tiered pilot program that aims to build upon the existing national program for childhood immunization and developmental screening. In Tier 1, the children go through standard care according to our national schedule. On top of this routine care, our Tier 1 nurses perform additional tasks within the same appointment time slot. In Tier 2, children are transferred to a new station that's specially set up for this program. Here, they are seen by polyclinic nurses and doctors who have received training by our pediatric colleagues from KK Hospital. Cases requiring further management are then referred on from there. Next. There are 3 main focuses at our hub. The first is postpartum depression screening. The second is childhood nutrition and growth. And the third is child development. Apart from upskilling our services to better pick up and manage areas of clinical concern, we also aim to step up engagement and empowerment of caregivers through parenting education and counseling. Next slide. To screen for postpartum depression, we incorporate the quick and simple PHQ-2 into the first most standard infant outpatient visit, which is at the 2 to 3 month old time point. We also hand out brochures on postpartum depression to create awareness. If the mom screens positive, she goes to Tier 2, where a nurse will provide counseling. After which, they are either referred to a psychiatrist or to our community mental health partner. Since July 2019, when the program first started, we have screened a total of 2,479 moms and picked up depressive symptoms among 2.5%, of which almost half have received intervention from our program. Next. We also noticed that there were some moms who declined intervention. Hence, we added in a follow-up call at 2 weeks and also point them to the helplines that are printed on the brochure that they were given at the first visit. Next slide. Our second focus is on promoting healthy growth and nutrition and preventing childhood obesity. At Tier 1, the child's height, weight, and BMI are measured and charted at each standard well child visit. Here, lactation and weaning support is also provided at this level. At 18 months, if the child's BMI is greater than the 90th percentile, they go on to Tier 2, where a nurse will provide basic nutritional counseling. The child may be referred to the clinic's dietitian, and a follow-up with a Tier 2 doctor in 6 months can also be made. If the child is found to be more than the 90th percentile, then they get referred to a pediatrician. To date, almost 1,500 18-month-olds have been screened, with about 10% who have been screened to be at risk for obesity. Next slide. Last but not least, for the enhanced developmental screening, we added new screening tools on top of the nationally used health booklet screening questions at the 9, 18, and 30-month touchpoints to improve on the early identification of developmental delays. At Tier 1, we added the PETS and PETS DM questionnaires, while at Tier 2, we administered the more time-consuming ASQ and MCHATs. Those with abnormalities are then referred to the child developmental units of the hospitals. A total of 3,628 children have come through this enhanced program so far, with 5.3% of them screening positive for developmental delays across all 3 time points. Our interim analysis shows that the yield is the highest at the 18-month touchpoint at 10%. And among the 18-month-olds, the referral rate was twice more with this new screening program when compared to our clinic's referral rate before implementing this program, and also twice more compared to other polyclinics without this program. Our program continues to evolve as new data emerges. For example, we added in new questions at the 18-month touchpoint to improve on the screening for language delay, while on the other hand, we removed the 9-month touchpoint as the yield was found to be very low.
We also noticed that while the referral rate had gone up, the defaulter rate at the hospital and the number of patients who had declined referrals were quite significant. Because of this, we added a 6-month follow-up for such cases to ensure that no child gets left behind. We are proud to share that our data has helped to influence the latest National Child Development Screening Guidelines, which was recently rolled out earlier this month. And the team hopes that this program will eventually be scalable to all polyclinics in Singapore. Thank you.
Thank you. Really enjoyed your presentation, and I really like the structure of the tier 1, tier 2, and referral, because then you've assessed, thousands of patients in each category, and if I remember right, about 2.5% had maternal depression, 10% the child had BMI nutrition challenges, and here 5%. So they're small but significant percentages, and you've got a very structured way of moving the patients that need it, the individuals that need it, to the next levels of care. So great program and very well described. Do we have any questions or comments from members of the audience, the participants? Okay, hearing none. Thank you so much, Doctor, for your presentation. We'll now move to our final presentation. And I believe Dr. Lau is going to be presenting for Dr. Thumbo. Dr. Lau, please proceed.
Yeah, thanks, Dr. Good, and a very good day to all our participants again. I'm making this presentation on behalf of Professor Julian Tambu, who is actually our research director for the regional health system at SingHealth, Duke NUS Academic Medical Center. So again, thank you for the opportunity to present our work on how we develop an academic health system perspective to developing population health research agenda to improve outcomes. Next slide, please. So the SingHealth Regional Health System, or RHS for short, manages the population in the eastern part of Singapore. This is a population of about 1.4 million. And the regional health system has been driving the development of population health research in our academic medical center through a very iterative process that involves the community in the co-design of programs and the research agenda. So very critically in developing the research priorities, we wanted to engage our key stakeholders, and these are the communities and the patients that we are serving, to deeply understand their needs and then co-design programs and interventions with them with the purpose of empowerment and activating the communities. The co-designing process uses an evidence-based approach, starting with identifying the problems to be solved at the population level. Subsequently, we then leverage on existing programs to pilot new interventions as they were likely to have the necessary infrastructure and resources to kickstart these pilot studies. And then we use these findings to help us to refine these existing programs, working very closely with our community partners to then incorporate program evaluation and monitoring frameworks for various process and outcome evaluations. Subsequently, we share this data back with our community partners, with government agencies and program owners to provide feedback on where areas of improvements can be, and also encouragement where programs have done well. We then identify further gaps that we need to guide future research. Population health research is still at a very early stage in Singapore, and therefore we've encountered a number of challenges so far. And we have actually leveraged on quite a few key enablers to overcome some of these challenges. Just very quickly, very briefly, some of these key challenges include the need to develop a population health database for systematic collection and integration of population data. We needed to develop a population research panel comprising of stakeholders and citizens in our population for qualitative and quantitative surveys of the community needs. And we also develop a population evaluation framework leveraging on implementation science and realist evaluations. Next slide, please. So in this slide, you see the various research teams as well as research core facilities that we've developed funded by a central grant from the Ministry of Health Singapore to develop a population-based learning system for enhanced and sustainable health. And to address many of the critical unmet needs through stakeholder engagement, we have actually identified 4 research teams from the onset. These are population segmentation, diabetes, because we have a war on diabetes in Singapore with one of the higher rates of complications post-diabetes. Looking at patients with complex needs, as was articulated in Dr. Kong's presentation, as well as a rapidly aging population with pre-frailty and frailty. These 4 research teams are then supported by 5 facility calls to address these challenges. So these include implementation of behavioral science, data analytics, financial analysis, a living lab platform for community mobility, and finally health engagement and action labs, including a research panel. And we evaluate the success of our research agenda by the quadruple aim, which looks at population health, per capita cost, satisfaction of healthcare providers, and so on. The next slide, please. So a good example of how we have leveraged on our center grant to improve health outcomes is on pre-frailty and frailty. So we know that the prevalence of pre-frailty in Singapore is high. However, there's no standardized and effective screening tool for community-based screening. And this is something that many geriatricians and rehab physicians struggle with. So through this research, we developed the IPPTS, or we call it the Individual Physical Proficiency Test for Seniors, which is a multi-domain, which comprises a multi-domain rapid geriatric screen, as well as a physical fitness test battery, with the aim to validate a simplified screening tool. This is in collaboration with our community partners, so our senior activity centers, family services centers, as well as community centers. And the study has been completed with more than 1,000 seniors screened, and now we're in the process of validating this simplified screening tool. But we don't stop at just screening for the seniors. We then right-side them to various interventions that are focused on their frailty levels. So for example, if they are pre-frail, they will then be referred to intervention programs that comprises of a very structured exercise and nutrition programs with regular intervals at 3, 6, and 12 months post-intervention. And then we measure how effective these programs have been in slowing down the development of frailty or even reversing frailty status in this group of seniors. For the end of the spectrum, where the seniors are very frail, they are then referred to community-based programs such as our Geriatric Services Hub that provides more coordinated and integrated care pathways for frail seniors in the community. And in this group, the aim is to then ensure that the health, functional, and social care needs are integrated, and the seniors are appropriately attending day rehab centers where they can attend structured programs to reduce care burden in the community. So to support such research agenda for the entire frailty spectrum, it really comprises all our facility calls, like our community mobility platform that included our physiotherapists and research coordinators. There was a lot of data analytics ongoing, and most importantly, behavioral and implementation science to really test various interventions on what works, why, and for whom. Next slide, please. So as an academic, learning academic health system, we recognize the need to constantly generate evidence that can lead to improvements in care and in population health. We need to evaluate our implementations scientifically and in an evidence-based way. And with this evaluation and research, generate more evidence to be implemented in the health system to improve care. Such research aims to improve population health as a whole, and also addressing the other aims in the quadruple aim, such as the experience of care, the satisfaction of our healthcare providers, as well as ensuring sustainable costs. So moving forward, we see that the academic health system plays an important role to partner with the community as well as various government agencies to continue to strengthen the research infrastructure in the community, develop expertise, in particular implementation science and program evaluation, because many of these interventions are complex in nature. They're not easy to evaluate in a simple laboratory setting. And finally, we really look forward to collaborations and strong research partnerships with our regional and international academic health system partners. And with that, thank you again for your kind attention for this short presentation, and look forward to your comments on our health systems approach to this. Thank you so much.
Thank you. And I particularly like your last slide and your last explanation, because really the Academic Health Center is in not only in the ideal position, but perhaps really the only organization that can bring all of the different elements together, just as you have explained, partnering with the community, understanding the health issues, assessing them, the implementation science parts of this, then the reevaluation. And so I think this was a particularly nice talk to conclude our series here today. Again, I'll pause. Any questions from our audience members? This has been a particularly quiet audience. I'll also ask our presenters if they would like to ask their colleagues, some of the other presenters. Any questions here as our time wraps up on this session? We probably have time for one or two more questions if anybody would like to ask a question. Okay, I'm not seeing any raised hands or comments coming forward. In the chat box and also on the screen now, you'll see a website link to the Association of Academic Health Centers, the President Council's website, these presentations and posters, as well as the posters and presentations from the session we had at the meeting in the United States, are all gathered on the President's Council website. I'd like to really thank our international members of the Association of Academic Health Centers International. I'd like to thank the Southeast Asia region in this regional meeting. I've certainly learned a number of perspectives and different approaches, and hopefully we all have, and we'll go back to our institutions and continue to lead important work in making the health of not only our individual patients, but making the health of the population in our communities better overall. Again, as I said before, really work that only the Academic Health Center can do. Have a great day. We now enter a short break, and the session will resume at 9:30 to discuss COVID-19 treatments and vaccine development. For now, we sign off. Thank you all, and have a good day.